to our, sorry, let the recording start. I want to welcome everybody today to the Spokane County Regional Interlocal Leadership Structure Meeting. It is March 18th, 2022. It's 2:30, and we will go ahead and get started. Thank you all for attending today. We're excited. I think we've got an action-packed agenda. And so Kathleen, I'm going to let you go ahead and take it from here.
Okay, great. Thank you, Commissioner Cooney. I'm going to keep my camera off simply because I'm having some breakup. And so I don't want to not be able to hear and see things. So I hope no one's offended by that. So I'm going to go ahead and start with the agenda. The Governor's Office of Amber Leaders is not available today to give an update. So we'll move on to the next item. And I'm trying to quickly scan, but we have so many people, it's hard to see. But is Jason McGill on the call or in the meeting? Not hearing his voice. I'm going to move on to Evan because I can see Evan on my screen and have him provide us with the legislative updates from the session that just completed specific to behavioral health. Welcome, Evan.
Oh, thank you. And good afternoon. Happy Friday, everybody. I'm Evan Klein, the Special Assistant for Legislative Affairs here at Authority. Here, legislative for took on role over, but excited to be here. Thank you for having me, and happy to provide you on legislative session.
Evan, just a second. I'm going to just ask people to mute. There's a couple of people that have come on late that are not muted that we're getting some feedback. So I want to make sure everybody can hear you properly. So if everyone can mute, that would be great. I think there's someone on the phone that is not muted. Thank you very much. Okay, Evan, you go ahead.
Perfect. And what I may do, I know I'm on the agenda twice today. I may, I'm going to provide you a bit of background on both some policy bills that came through this legislative session and the budget. One of those being Substitute House Bill 1735. So I may kind of weave the update on House Bill 1310 into this presentation if it's okay with you all. But happy to stop and take questions throughout as well. So just a little bit of brief background, just to give you some sense of scope for this legislative session. Pretty extraordinary year for the legislature, especially being a short 60-day legislative session. The legislature was debating a supplemental budget this year, so not the full 2-year operating budget, but just really looking at the supplemental kind of second half of 2022 and then first half of 2023 in this year's budget. But there was a ton of new tax revenue available to the state. And so we saw some pretty significant investments from the state legislature to the tune of around $5 billion of additional spending in general fund state dollars during this year. And the agency's budget itself between state and federal funds grew by over $1.5 billion during this year. So that just kind of gives you a sense of the scope of total investments in behavioral health and physical health programs, largely through the Medicaid program, but also as part of kind of our public employee benefits as well. So I'll start by just walking through some of the policy bills that were enacted this session. My focus is going to be on behavioral health throughout this presentation, and I'm not going to be able to touch everything as I provided in that brief background. There's a ton that came through this legislative session. On the behavioral health side in the budget, there were something in the range of 46 new budget provisos simply impacting our agency. So just giving you a little bit of flavor. With policy bills, there were a handful of policy proposals that really kind of impacted the health sphere. One of the biggest of those was House Bill 1866, which is the Apple Health and Homes program. This was a bill from Representative Chop that looked at pretty large scale investments, particularly through the Department of Commerce in housing for the homeless population in Washington. For us, there's a lot of connectivity in there to the Foundational Community Supports Program. So the work we do through FCS to connect folks with supported housing. And so We're going to hit the ground running with implementation on a lot of those efforts. There's over, I think, $130 million in investments in actual brick and mortar capacity. And then, we provide a lot of that bridge as an agency between Medicaid and the behavioral health system and connecting folks to housing. So it's an extension of some of the work we've been doing under the 1115 transformation waiver. Another bill is House Bill 1800, which requires HCA to dedicate a specific FTE to connecting families, behavioral health providers, educators, and stakeholders with behavioral health services for minors. It's really a focus on minors, and also the implementation of a parent portal. So the creation of kind of a portal on our webpage so that parents can connect with behavioral health services for minors that they might be caring for. Another bill was House Bill 1890, which was looking at kind of an extension of the Children and Youth Behavioral Health Work Group. So it requires that work group to develop an advisory group to think through a strategic plan specifically for children and youth that are transitioning to adulthood. And then it increases the work group membership and allows for some stipends for those members. So really kind of doubling down on a lot of the work, great work that has been happening from that group and in that space. Another bill that wasn't specific to the behavioral health world, but I think will have some pretty interesting downstream impacts. So I want to note here is House Bill 1688, which was around balance billing protections. In large part, it was a reconciliation of the state's Balance Billing Act and the federal No Surprises Act, which passed last year, with some federal prohibitions around balance billing, and that being kind of when you receive coverage from an out-of-network provider and could be charged outside of your commercial insurance. But the state legislation included some provisions around crisis stabilization, evaluation and treatment facilities, and BHASOs and triage facilities, prohibiting balance billing when an individual receives emergency services in those instances. So kind of thinking beyond just the emergency room and again, kind of looking at the direction of trying to ensure that those provider types are included in commercial insurance coverage so someone's not balance billed when they receive those services. Then there was Senate Bill 5736 around partial hospitalizations. It's really an expansion of a current pilot program that has been funded in the budget to require reimbursement for partial hospitalizations for individuals under age 21 statewide. And that will go into effect January 1st of 2024. So we'll be working through a state plan amendment and then implementation there. And then the last bill that I was going to touch on is House Bill 1735. And as is noted kind of on a separate line item here, it's really an update to House Bill 1310, which passed last year. And it's focusing on use of force for peace officers. House Bill 1310 was enacted and created a little bit of confusion in that space around when a peace officer can utilize force, especially in dealing with behavioral health crisis and working with kind of other partners in that space, especially behavioral health professionals and other social service providers. And House Bill 1735 was really directed at clearing up some of that confusion. It created some definitions and a little bit more certainty around when a peace officer can and cannot utilize force in that space. And I think we're hearing that that police officers are more willing already to become involved in behavioral health, instances of behavioral health crisis due to some of the clarification that was provided in this House bill. And it was effective immediately, had an emergency clause on it. So that is already effective. It was signed into law by the governor, I think, on March 4th. So I'll pause there. That's kind of my wrap up in large part of the policy bills that passed. And then I was going to transition and focus on some of the items in the budget, but just see quickly if there's any questions or other items that you'd want me to touch on. I see a question from Jeff, looks like.
Go ahead, Jeff.
Yes, thank you. Just speaking to the 1735, yeah, that to say it was, kind had some interpretation issues, states it mildly. It was, you know, hugely problematic. In our region, we experienced about over the 8-month period, it was in fact roughly a 25% or close to it reduction in individuals who were detained under the ITA laws. And that's not because there was that much of a drop in people needing that service. That was just because of law enforcement's interpretations. And that's not mine to question whether it was accurate or not, but it was the challenge that it presented in terms of them responding. And so, yeah, in speaking with our sheriff and our police chief, the language in 1735 is sufficient to have them kind of reinstate previous practices. But in both cases, they stated it doesn't happen on a dime. It was made effective immediately on March 4th. But you know, it's taking a bit of time to then communicate, train, retrain their staff to be amending their practices. So we've not yet seen the impact of those changes, but we anticipate that will be, you know, over the next few weeks, it will be moved into effect. So thank you.
Great. Yeah, I appreciate that context. Awesome. So I'll transition, just be cognizant of time, to budget items. Again, just hitting on some of the highlights. This isn't everything, but happy to take questions. A lot of investment in the behavioral health workforce and funding the behavioral health workforce for recruitment and retention. There was a $100 million proviso around provider relief funding for kind of funds to be driven out to behavioral health providers throughout the state in 2022. And then that's kind of acting as a bridge in large part to a 7% rate increase that takes place in January 1st of 2023. And that's both for providers offering services through BHASOs and through Medicaid managed care. So we were excited to see those investments, and we'll be working to turn around the behavioral health provider relief funding as soon as we can. We don't get that funding into kind of our accounts until July 1, but I think that the Medicaid team is really looking to try and drive out those dollars as quick as possible, and hopefully no later than, you know, September or so. So kind of a, you know, 2-3 month ramp time to get all that money out. There was some support in the budget for FTEs here at the agency in the behavioral health world, in large part to backfill kind of historical capacity issues that we've had with trying to stand up, implement, and operate all of these critical programs. So we were appreciative of that investment. There was the creation of 2 new grant programs. One was to input community health workers into pediatric primary care clinics throughout the state. There was $2 million invested in that program. And then another $2 million invested, again, kind of with the focus of pediatric primary care, but more around other kind of broad investment opportunities for those clinics. So it allows for grants of up to $200,000 per clinic to focus on systems development, patient registries, recruitment, partnerships, but also like IT, EHR, other kind of investments that some of these clinics might not have been able to make absent some state resources. There was funding for an uptake for an increase in CLIP beds throughout the state. And this was a decision package that we had as an agency. So we were excited to see this get funded, but a phased approach, increasing the number of funded CLIP beds from 37 eventually up to 72 by fiscal year 2023. And then there was funding for kind of an increase in investment around the Certified Community Behavioral Health Clinic model, the CCBHC model. So both an additional $5 million provided in bridge funding to extend the existing grants for CCBHCs, but then also some funding to the agency to work towards a longer term sustainable funding model and report that back to the legislature. So we know that that's going to be a lot of work this interim, and probably a lot of stakeholder engagement throughout communities to understand, you know, how could we sustainably fund this program into the future. But we want to, you know, work as diligently as we can to come back to the legislature with more information to help them make an informed decision next session about making some of this sustainable as opposed to just funded through a grant program. And then there was additional funding for mobile crisis teams. as well as a couple of opioid investments, mobile opioid treatment and opioid awareness campaign, a rate increase for opioid treatment providers, and then some funding for an overdose and harm prevention program, particularly through syringe exchanges. So all of that, we're excited to see a lot of those investments in SUD prevention came from decision packages that we had provided to the governor's office and that the governor had proposed funding in his budget. So excited to see that make its way through the conference budget and out of the legislature. So other than that, there's some IT investments and some other investments in the physical health space, particularly around authorization to spend funding around 1115 transformation waiver, which we know has some impacts on behavioral health integration. But that's kind of the highlights for behavioral health. I know is really quick and fast, but I want to make sure I save time for others today. So I'm happy to take questions, or otherwise happy to turn it over to my colleagues at HCA.
Does anybody have any questions for Evan? Not hearing any. We'll back up a little bit in the agenda because I do see Jason McGill is on. And Jason, if we could ask you to maybe cover both the different items that you're on. Start with the expanding Medicaid item, if you would. And welcome.
Yeah, and love to just continue the conversation there that Evan started with regard to behavioral health rates. And although I think you covered that well, I think as we discussed in our previous conversations about the current situation with regard to Medicaid managed care plans interested in extending into the Spokane region, United Health is interested. We are not entertaining that expansion currently. I have had some very good conversations with the CEO of United, who I believe is working as I believe makes sense to continue outreach and engagement with providers who are interested in further discussion. So I think that is ongoing, but just again, confirmation that we are not extending that in the short term. Now, that leads me to indicate when might we, as you might be interested, and I don't know, but we will likely over the next few years have to look into a new procurement and opportunity for managed care in Washington. We haven't really opened up the managed care contracts since even prior to Medicaid expansion. Really, it was 2012, the last open competitive procurement. So that is work that we are doing and considering now. So in full transparency, at some point in the future, whether that is a couple years, 5 years, I don't know the details as of yet. And we're working through that process to determine what it would look like. And then, as you know, through an open procurement, that doesn't mean there'll be any new plans, but there could be. So I just wanted to be transparent and clear with you that that is also work we're contemplating at the Healthcare Authority with regard to potential expansion. Again, I wouldn't assume it, but nonetheless, it is possible when you do an open procurement. So maybe I'll pause on that before then transitioning off of Evan's comments, particularly about rates and workforce.
So does anyone have any questions for Jason based on his update? And I see David Nielsen has his hand up. So David. Hey,
David.
Hey, Jason. So this may be way premature, but I'm going to ask the question anyhow. When we went through the original process of getting into IMC, the Spokane area was told that we would have 4 MCOs. If we go through a new procurement, is it still going to be 4? Is there any possibility that it could become 12? What might that look like?
I can almost guarantee we would not contemplate more than 5. But but we are working on that now. So I don't have an answer per se, David. Again, when you do open it up, and we have to work on statewide as well as considering regional impacts. So we have to balance that. We'll see. We're working on those details now, and I should also caveat that I'm not sure we would share that level of detail prior to actually publishing the RFP. But I do appreciate any input you might have, and I hear you loud and clear, no more than 4, or please share with me any feedback you might have, and I will listen.
Great, thank you. And just one other question tying into the new dollars that are coming into the system. So as I've been thinking about our payment mechanism, we've certainly had fewer services that have been provided over the past year as a result of loss of workforce and workforce reduction. And I'm a little concerned that new dollars could be coming into the system that's supposed to be going out for salaries and workforce retention, but at the same time getting overall lower payments based off of less service provision over the past year. Has there been any thought about how we try and balance that out? Because if we suddenly do get lower payments, even with the salary potential increases, the net effect is we're going to be driving down the number of behavioral health clinicians in the Medicaid system. Thank you. I'm done with that.
Well, yes, I think this is a good transition to our provider rates. And I think my partner here, Michelle Wilsey, I would love Michelle and Teresa Claycamp to chime in. And then it also transitions into workforce. And my colleagues, Steve Perry and Suzanne Swedner is also on, and welcome all of my great colleagues here at HCA. David, right off, the $100 million will likely apply in some manner based on a formulaic approach for utilization. So good news and bad news. Good news in the sense of we can open that up more quickly than a grant and application process that would take time to get those dollars out the door, but perhaps not as carefully looking at, say, residential challenges in terms of filling residential spots, which I understand are particularly challenging and has been in terms of some of the funding needs and recruitment staffing needs. So I think there's a balance there that we're working through in terms of how we want to distribute that $100 million immediate funding. Now, the 7% funding is dictated more clearly. And it will be a directed payment. It will be paid just like that 2% increase from October was paid. And it will be a pass-through payment through managed care. So it will be an additional 7%. Now, yes, it's on utilized services, encountered services. So, again, a balance on that, David. But that is what the legislature chose to do. And I think that's probably for system and for Medicaid match legal approval to obtain the federal dollars for the services. I do believe that makes a lot of sense. Michelle, are you on? Do you want to comment further on that question from David?
I am on. Hi, everyone.
Hey, Michelle.
And Jason, I think you're spot on. There is that $100 million in provider relief, which is helpful. We do recognize that some of the facilities that have had to change their practices may have experienced lesser census due to the results of the data. We will be looking at that as we do our rate setting processes to make sure that we take that into effect.
Maybe it's worth, Michelle, what do you think, also touching on, I think, two important, more long-term, although you heard Evan talk about the CCBHC model as potentially something we'd bring to the legislature next year. But we have two things underway. One, the CCBHC now approved to do a real study to determine sort of cost-based and outcome-based models, and some of you may be experiencing working through the CCBHC pilots now, and really pretty phenomenal results. The other piece of work that we've already begun from last budget is what we call our behavioral health rate comparison study. And we think that study will very, helpful inform the CCBHC work, and then really tell us more about what is the real costs of services for our behavioral health providers. So looking a little bit more long-term to develop more sustainable options, to Michelle's point with regard to developing rates for managed care. And I see Jeff's hand. Hey, Jeff.
Hi there.
Good to see you.
Yes. So, you and I have had a number of kind of email conversations around this, and I just wanted to kind of confirm this form too, that the 7%, it's funded at a level from the state to the MCOs to support a 7% rate increase for all those services that are paid for under Medicaid funding through the MCOs in a region. Is that accurate?
Behavioral health.
It's not limited to outpatient. I mean, it would apply to WISE, it applies to inpatient. I mean, that funding goes to the MCOs to support all of those services. Is that correct?
Yes, and again, through a directed payment format. So those dollars should pass through directly as a 7% increase into your contracts.
Okay. No.
I will just plug, if you're having problems with the 2% from last October, let me know, but I am not hearing any problems. And I think our managed care plans have done a really good job prepping for that. And I'm hearing pretty good results in getting those 2% out the door. So I'm really very proud of the plans to get that done so quickly and so well. So my hope is that this 7% will build on top of that pretty easily. Again, won't start till January because of the timing with regard to CMS rate approvals.
Exactly, but yes, it's and recognizing that the 100 million is sort of designed in using different terminology, but be sort of a bridge toward that. And I know many organizations, if not most, are, because of the workforce shortage crisis we're in, are looking to, as soon as possible, have a sort of secured knowledge of what those dollars will be, such that we can be parlaying that into compensation decisions, to address the issue. So
exactly.
Yeah.
I will, maybe I'll take an opportunity on that 100 million just to emphasize too. One, I think Evan said our commitment to try to do that as soon as possible. Now we're working through some of these important details now, so I cannot promise a July date. The money doesn't hit us until July, of course, because the budget is not effective until July 1. But we'd like to try to do it as soon as possible. So we've already begun that work here internally. And we do have, again, some experience with a similar, sort of more formulaic model through, if you might recall, the end of 2020, we had some CARES Act dollars that we pushed out to behavioral health agencies. And we're thinking of doing something very similar this time around. So my hope is to have it as soon as possible post-July. I can't guarantee it, and thinking probably no later than September at the latest. So that is a real bridge funding to January. I think it's really important. And maybe the second point to make on that is they did use ARPA dollars to help fund it. And there may be some, I fear there may be some questions about that, because that does come with some requirements, but actually many fewer requirements than the previous CARES Act dollars from the feds. And I think we'll be just fine in terms of no real handcuffs on these dollars to get them out the door effectively and efficiently.
Mm-hmm. Yeah, you're right, Jason. That was one of the big concerns, is if that was tethered to COVID-related losses,
right,
that becomes much more constrained and challenging than really the big crisis that we're all experiencing now, which is just not enough, staff staying because of the compensation.
Yeah.
So
I will say on that point, though, there is a requirement to do some reporting on this. We're looking at how to do that most effectively, so we don't burden you with one more thing. So we're thinking on that now too.
And one other just confirming or clarifying question, Jason, while it got you here, is it the case that I'm hearing on the 100 million, it might end up being as, say, simplistic but straightforward as looking at out of the overall Medicaid dollars spent on, or dollars spent, but on behavioral health services over a given period, say 2021, just whatever that proportional breakout, that just sort of becomes a simplistic way to say if one agency had, 0.5%, somebody else had 1%, that might be how it flows, or is that too simplistic way to think about it?
Well, I think based on encounters and then choosing that period of time, I think those are the questions we're looking at, so we can develop that most efficient formulaic approach. I don't know, Michelle, if you had thoughts on that, or to Jeff's question.
I think we're still working through how it's actually going to work and how we're going to make sure that it goes out in the best way possible.
Yeah.
Okay.
And I want to give time, Steve and Suzanne, maybe this is a good point of transition for some additional workforce work, a lot of work underway. But I'll stay on, and if you have any further questions, although I do have to transfer the phone and go get a kid from school. So anyway, it was very good to see you. I'll stay on though.
Thank you, Jason and Michelle. So let's pass it over to Steve. I know Steve's on, and I think Suzanne is too. So Steve, do you want to go ahead?
Yeah, thank you, Kathleen. Would you mind if I shared screen? I'm going to cover some materials here, and I can also show the slide deck on it.
Joanne, can you share your screen with Steve, please?
Yeah, and while that's happening, good afternoon, everyone. Thank you for the invitation to be here today. My name is Steve Perry. I'm with the Healthcare Authority in the Division of Behavioral Health and Recovery, and I'm here to share a few updates on workforce initiatives.
So I paused my share, so if you want to see if you can now.
It says I cannot start share screen while other participant is sharing.
Okay, how about now?
Yes, looks like we're gonna get it.
Okay.
Okay, so hopefully you're seeing my screen there.
Yes, we are.
Okay, thank you. To begin with, worker shortages is a national problem for all businesses in all industries. According to a report published in 21, 4 million people quit their job in the first half of last year, and another 4.5 million people quit their job in the last half of last year. According to a U.S. Chamber of Commerce report published in June of 21, the top problem facing businesses is their inability to hire enough workers. They went on to say that American businesses of every size, across every industry, in every state, are reporting unprecedented challenges filling jobs. There we go. Okay, one of the many challenges for the behavioral health workforce is that there simply aren't enough people coming into the industry. We're fortunate, as you heard here earlier in Washington, to be expanding services and access at a time of such great need. For the second year in a row, the legislature has made unprecedented investments in behavioral health, about $250 million in new behavioral health spending, or as Michael Langer likes to put it, $250 million. Including a 7% rate increase, $100 million in provider relief. These investments, as great as they are, won't solve worker shortages. In some cases, they'll put a little more pressure on our workforce. We simply need more people. For this reason, the Healthcare Authority kicked off a media campaign in September of 21. The goal of the campaign is to encourage more people to join the behavioral health workforce by raising awareness of the many career opportunities and financial resources available to help with education costs. Phase 1 of the campaign ended in December. We're waiting for a federal allocation to start phase 2. The landing page, startyourpath.org, is the landing page for the campaign. In phase 2 of the campaign, we'll be expanding target audiences to include unemployed workers and career changers. We'll add taped provider interviews showcasing a variety of jobs in prevention, treatment, and recovery support. We'll be working with colleges to align and leverage their recruitment efforts. We'll engage a celebrity spokesperson to promote the value of working in behavioral health. We'll expand our focus on diversity, equity, and inclusion. And we'll be developing a community toolkit to support local marketing and awareness efforts. We'll need help finding providers who are willing to participate in taped interviews. We'll also want input to identify materials that would be helpful for toolkit to support your local marketing and awareness efforts. I'll be sending out an invitation to participate in interviews in the coming weeks. And in the meantime, if you or someone you know is interested, please feel free to share my email address with them.
How's Amanda's job going?
A few months ago, a small team of healthcare employees were invited to meet with ASO MCO clinical coordination workforce ad hoc committee to discuss workforce needs, strategies, and opportunities to leverage efforts. Increasing certified peer counselors and addressing licensing delays were two top concerns that came out of that first meeting. Following that meeting, DBHR workforce provided an additional $400,000 to increase certified peer counselor trainings, which will add about 17 classes and support approximately 680 new peers by July of 22. DBHR is also increasing efforts to market train the trainer opportunities for providers or payers to provide their own trainings. Testing would, of course, still go through the healthcare authority, but providers and payers can also purchase additional classes if they wanted to help meet their local needs. Regarding licensing issues, the Department of Health launched a credentialing action plan in September of 21 to address challenges and delays. They've hired a number of new staff to reduce backlogs. And if you're interested, you might consider inviting them to present to this group. Let me know if you want to contact for that. Last year, House Bill 1504 established two programs, 3 pilot programs to incentivize supervisor and intern pay, and a training support and grants program to provide flexible funds for industry-led training. Both programs are now in contract with accountable communities of health, and provider procurements are underway. The 2021 operating budget called for the authority to convene a work group to develop standards for classifying a behavioral health agency as a teaching clinic, develop recommendations for an enhancement rate for those clinics. The healthcare authority is working with a group of providers to identify costs associated with those activities. The analysis is currently underway, and the report to the legislature has been extended through December of 22, so later this year. That really was all that I brought with me today. I'm happy to answer questions, if any. If not, I'll send these slides to you. I didn't have time to get them to you prior to today, but I brought along some resources that are included in these slides on recruitment, retention, and onboarding, and then of course on loan repayment and scholarship programs. So thank you again for inviting me here today.
Steve, thank you. And can you send us your presentation and then we'll share it out with the members?
Yes, I absolutely will.
Great. And then you want to release your screen so we're not looking at your screen.
Yeah,
You can see your calendar right now.
Let's see here. How do I get that up?
So thank you, Steve, and all of the HCA representatives for being in attendance. And we are a little bit over, but I will take a pause to see if anybody has any questions for any members of the HCA team that might still be in the meeting.
So Kathleen, if I could just really quickly, I think for all of our Eastern Washington commissioners' perspective, first, we're grateful for the legislative fix that's coming to us financially with the 100 million and the 7% for 2023. But I really am concerned about kind of the thinking about how do we get this money out. So as I look at my agency, we serve Ferry County, Stevens County, and Lincoln County. In one of my agencies, at one point, we were down 60% of our master's level clinicians, and we've never rebounded from that. Another one of my office locations, I normally have 4 full-time master's level therapists. At the end of March, I'll have 1. And as a result of that, clearly our service numbers have crashed, not because of a lack of need, but because of a lack of workforce. And what I'm seeing in some of my contracts with the MCOs right now, which is what I'd probably be doing if I was operating those MCOs, we're seeing that, for example, enhancement dollars that we have gotten historically that used to come to us at the rate of X is now coming to us at the rate of X minus 20% because of reduction in services. So even as new money comes to us, if it's going to be based on utilization during a time that we were in the midst of significant workforce shortage from which we have never rebounded from, my concern is that the funding will come, but it will only be funding us all at a reduced level of workforce capacity. And I don't know then how we ever expand out of that. So I just really kind of urge our commissioners and our healthcare authority partners to be aware that if funding is going to be based on utilization of services in the midst of COVID, what we're going to ultimately be doing is taking care of a significantly reduced workforce rather than our pre-COVID workforce. Thank you.
Thank you, David. And I know Michelle Wilsey is still on. I don't know if she wants to respond but I know she was saying that they were going to be looking at considerations for factors like that. That's what I understood. Michelle, do you have anything you'd like to say?
Hi, yeah, I can address that. You know, the Medicaid system obviously is not a pay for capacity system. It is a pay for services system, but that doesn't mean that we can't take a look at what those actual costs are. And we've been doing a lot of significant work in benchmarking, and some of the funding that we have coming through has actually continued that funding for the benchmarking for us to make sure to reflect the actual cost of that. And part of that takes into consideration not just your turnover ratios, but your vacancy ratios in your facilities as well. So we've been working through that. And the work that's being done with that is being done by our actuaries who do the rate setting for the Medicaid program. So we can certainly make sure that that is on their radar to take a look at as we work through the whole process of getting the rate setting done, getting that money out there, and then also as we work through that benchmarking. I know there's been a lot of conversation with the providers that volunteered to be on those work groups regarding turnover and regarding vacancy rates.
You know, and this, Jason, still on, I think, Michelle, that's perfect in terms of Medicaid funding. I think that covers it. Again, really not a capacity funded item because the feds don't allow it. However, the 100 million, my takeaway from you is to consider potentially pre-COVID level services and service utilization. And so at least that is one potential takeaway here, as I understood your comment, Commissioner. Or was that David speaking? And so I think good point made and something we will certainly consider.
And Jason, that was David. This is Jeff Thomas. Just I would underscore that completely. I think that's spot on. If that could be very, very seriously considered.
Are there any other questions from providers or commissioners for the Healthcare Authority before we move on in the agenda? Okay, not hearing anything further. Thank you to our partners at Healthcare Authority. And I think that David and Jeff's remarks are really important for consideration, and so appreciate Michelle and Jason, your work and your team's work with the actuaries on recognizing the complicated times we're in, and appreciate some well thought out formulas and methodologies for this funding that's coming out. So thank you. So we're running a little over on our agenda, and I just sent a message to Justin, and he said he was willing to be skipped on item 4. We'll do an update in our June meeting on that. I think everybody has a pretty good idea, but Justin will be covering 5 along with Mike Grundy from Excelsior. So I'm going to turn the time over. Justin, you have a couple minutes. Maybe you could cover what you can, and then we can move into the Excelsior item. So go ahead, Justin.
Kathleen, Chairman Goody. Just briefly wanted to provide an update on our work on getting the Recovery Navigator programs up and running in our regions. All of our counties have Recovery Navigator programs currently in place and working closely with the courts and regional law enforcement, and are already providing services. So a lot of great work already in place. But I wanted to provide that because a lot of the community leaders here in all of our counties worked hard to get this in place, as well as our providers on the call who are part of the RFP program. So you may be hearing this come out in addition as we begin looking at the implications of the 1735 in response to House Bill 1310 and law enforcement's expansion. So just wanted to highlight that. A lot of great work going on, and the 988 crisis system redesign is ongoing. There's a lot more work to that, and so more to come as we begin discussing that in region. And then shifting to item 5, so we can give some time for our Excelsior Wellness Center to be able to provide an update on the teen text line. Just want to give a little background on this project before I turn it over to Mike and his team. This is a joint funding project with the Healthcare Authority regarding some DMA funds, designated marijuana account funds, and some mental health block grant funds, looking to really address the challenges facing youth throughout our Spokane regional service area, and really trying to find the best place to do pre-diversion and pre-engagement with youth that are not actively engaged or involved in behavioral services, where services covered under Medicaid or commercial insurance isn't currently available. And so for that, we really targeted some key areas, including telecommunications and engagement, especially during COVID. And in partnership with Excelsior Wellness Center, we developed this youth behavioral text line, which includes web-based chat and phone line as well, to really integrate a peer-led engagement service that meets youth where they're at. Any youth within our 6-county region can access this line, and it's specifically tied to the services provided to our youth within our region. So really, again, addressing the needs that youth have, not while they're in crisis, but prior to crisis, getting them connected to behavioral services, irregardless of insurance coverage, to ensure that they are provided the necessary care, regardless of the issue, and then a warm handoff to those resources in the community in an effort to prevent any of the needs that would have escalated into a crisis. And so that's the impetus for this project with the support of our commissioners. This is something that we've been pushing really hard, really addressing youth and youth need throughout our 6-county region. And so a lot of other projects, but this is really a great one. So without further ado, I'll turn it over to you, Mike, to share a little bit of the project and give us an overview.
I am now audible. So good afternoon, everybody. My name is Mike Grundy. I'm the Vice President of Business for Excelsior and the executive sponsor of the Teen Text Project. Kayla Behringer is here with me today, and we're supporting our project through this demonstration. I am going to attempt to share a screen, if that's okay, Joanne.
Joanne, are you there? Can you share your screen with Mike Grundy, please?
I'm working on it here.
I think I did it. Did I do
Did
it?
we get it?
You
Okay.
can see it.
I think I
Okay.
pirated your screen from you. I hope that's okay. I'm sorry.
No, I'm fine with that.
Okay. So the teen text line started up 1st of December, and we have been working like crazy to get this stuff out there and marketed and branded, and get these teens aware of this resource that's available. And we're grateful to report that for the first time in February, we actually started receiving community texts. We got about 6 outreach calls that were not test calls. I would like to take a moment to make a public announcement that if you are testing this line, could you please let us know? Because if you do an anonymous call and you don't let us know that it is a test, we're going to treat you like a patient and use you in the statistics. But we did, in fact, glean all of these out of test calls and made sure that they were real calls, and they were. So we have started getting calls. I'm proud of that because we're putting a lot of work in. We have reached a point in our advertising where you can see in our pictures here that we have the branding that we have already made available, and everybody has seen this, I hope. In addition to that, we just finished our Snapchat video that we're planning on running in a flight of 3 weeks to further brand the product. I'd like to, this is a very short video. I'd like to just show it to you. We've looked at it. This is our first draft. Haven't sent it to Justin yet, but Justin's got to approve this before we launch it into advertising. So just a quick preview of this as it is being finalized. And I don't know if you can hear sound. I'm going to push the sound and see if that works. Can you hear that?
I can't hear it, Mike.
Okay. Sorry, you can't hear that. And I don't know how to fix that. So, share sound. There it is. Let's try one more time. Can you hear it now? Did you hear that?
Yes.
Good. Yeah, I did it. So this is going for approval out to Justin, and he signs off on all the media advertising. And if that gets his approval, then we will launch this on a 3-week flight for Snapchat and then Spotify. So we've got DH working on scheduling those run times in our region, in this local region, and they can do all that, which is a miracle as far as I'm concerned. But they're setting up to be ready to do that. That is what's going on in terms of branding. We have also reached out and actually made contact with some student advocates, what I call student advocates. Now, this is actually a step past certified peers. These are actual students who are advocating for the program, who are actually in school right now, who are in some way involved or have been involved in the current SUD community, and are able to give us a lot of insight and a lot of availability into that culture. So we're really trying to push this past the branding level at this point and begin to develop community involvement. We have our first planning committee working on that right now with some help from at least one sponsor from the student population, and we're hoping for at least 2 more get that started, to do park in the what we would call Summer in the Park series, where we are going to do a monthly outreach, provide a band, provide food, and also provide people who would be available on site at these events to be able to do support, intervention work, or be able to reach out and connect these kids with services. So moving a lot in the direction of actual direct community investment. And I think that's probably the biggest piece of what's going to be happening in marketing. And I want to turn that over for just a minute to Kayla to talk about all of the contacts that she's done and outreach that she's doing in the community right now as well.
Thank you, Mike. Hi, everybody. My name is Kayla Berenger. I'm a behavioral health clinician for Excelsior. Been working really hard the last month or two to just reestablish communication between Excelsior and our community partners in kind of this post-COVID engagement piece. We're working really active with all Providence providers, school districts, not only in Spokane, but the 6-county region. We've presented to DCYF in 3 of the 6 counties thus far. I've been in a majority of schools in town, met with their counseling teams, their behavioral health therapists on site, and just kind of regional providers, including FISBERT, to get the word out. We printed off about 2,500 flyers and then additional business cards to be able to hand these to providers who are working with youth that can just say, hey, this is pre-contemplative. Yes, you've got the regional crisis line, but this is just another resource for you to access peer support. And it's also this wonderful, robust guide of resources within the 6-county region. So we put a lot of time and effort into those manual admissions to the iCarol platform. It's being recepted very well within the community, especially Stevens, Ferry, Pend Oreille counties, who are really excited about this resource that gets gravitated towards their areas, not having as much as we have here in Spokane. So, just working really hard. I'm connecting with 5 to 10 agencies and schools a week where I'm traveling to them, kind of giving that presentation, and just being available to answer any questions. And it's been really well received thus far. So we're excited about it.
Thanks, Kayla. One last note about developments within Excelsior that are going to support this line. We just finished an agreement, a collaborative agreement with an organization called New Developed Nations, which works with music and recording as an outreach tool for youth to engage youth that are at risk in SUD environments and SUD behaviors. And we are excited about that because that is going to be another great connection for getting this community connected to this service. So that's what's going on in the development side and the branding and marketing side. We've got a lot of stuff planned for the summer. This is going to be a huge summer for us, getting this stuff out. We're working, as you saw, with Snapchat and Spotify to get the regional ads out and get those flights running. We're also looking at billboards and working with strategic placements on billboards to get that message out as well. So a big push on marketing. The other thing that we wanted to show you today was just a kind of a look at the software. So the software is another unique thing about this program. We purchased a software called iCarol. iCarol is well known across the country as a go-to software for call centers. However, it has a lot of neat modules built into it for handling resource referrals and connections with resources, and also maintaining a resource database that could be accessible across the Northeast region for providers. So we're planning on that being released soon. We had some setbacks with our website for the chat, hosting the chat. We have gotten those worked out, so we're moving forward with getting that up and launched by next week. And so what you're looking at here is the home screen, basically the home screen for the iCarol software. It's a great software for this development project because it's sustainable. It doesn't have a per seat licensure. It has a fixed annual cost, which is very reasonable and doesn't really break the bank. The other thing it does is allow us to really hone in on what this product actually does and create a referral network and a collaborative network across the 6-county region that we have partnerships with and agreements with to work with these kids. We can't handle all of the referrals, and neither can one provider across the whole region. But if we work together, we can provide the support that's needed to make this happen. So this is the homepage. We have staff available. We can do volunteer staff as well as employed staff. We can set up shifts that meet the needs of different types of staffing. We can also create supervision and real-time supervision to handle volunteer staff. And that's going to be, I think, a key factor moving forward as we begin to move more and more into the recovery community and begin to tap into that resource in terms of connecting with these at-risk populations. So volunteer staffing, we have the ability to do resource management and on-the-fly referrals. So I can, and I'll demonstrate this in just a second. We go into messaging here, and you can see that I have people online. This is part of our crew that is staffing the team text line and is available to answer these calls. For this time, I remembered to tell them not to pick up the call so that I could do it, and they're holding off. But I've had to text them a couple of times since we started. So these are 2 calls that are in the queue right now that I queued up a call from my phone, my cell phone, and I asked Kayla to queue up her cell phone and just call in and initiate a call. So I'm going to go ahead and accept this call from the queue from Kayla. And I am going to pick up that call right now. There we go. All right. The first thing that you notice is that all of the disclaimer language comes across the screen and tells you that you're working on a text line. Text is not necessarily a secure form of communication. If you'd like to continue, do that. If you don't, then just click stop and contact us by phone, or if you need to contact an emergency responder or the crisis line, those numbers are available as well. It also notifies you that I have joined the conversation. So in response to that, I would, can't I? And would respond to Kayla that way. And then she would get that text. I'm assuming she did, and then she would respond back, and we continue on. Over the course of the conversation, I can collect real information. Right now, she is operating anonymously, and we don't have her name in this. If she were to give us a name, we would key that in there and keep that as an identifier, but she still might be anonymous. We also have the ability to work with resources. So if I want to search for a resource, I would sorry, Push the wrong button. I would reach out with that resource and just paste that into her chat. So this resource would be available, and I would do a search on it and search for let's say food pantries or crisis food. And you can see that there are all kinds of food banks that pop up when I do that. I can also do a search. So if I were to take this food pantry right here and make a referral, I would paste that referral into the call. And don't forgive me for this, but I've lost my way just a second here. There we go. Okay. I pasted that referral into the chat here. So they have the phone number and the ability to reach out and contact that referral. I can do that with as many referrals as I need to based on the chat and where they might be. I can search for referrals based on zip code. If they're willing to give me a zip code, if not an address, I can search for the closest referral services that are in that area and get them connected up with people. We can do real-time connections with third-party calling if we can get them on the phone and do that, or we can just give them the referral and let them seek that themselves. We have the capability of scheduling future call follow-ups. So we can make an agreement with this person. If they remain anonymous for this call, we can make an agreement to follow up with them the next day and check in on them and see how they're doing and make sure they got to their referral okay, just by scheduling a next contact appointment. So I'm going to stop there. I know I'm just moving through the software. Are there any questions on any of this?
Nice work, Mike and team. This looks really great.
Thanks.
Thank you, Mike and Kayla and Justin. Appreciate the demonstration and information that you've shared with us. It's great. We're really pleased with it, and I think it will really attract a lot of teens. I think it's really a great forum for them. So thank you very much for putting it together and demoing it today for us. With that, we will have you release that screen and we'll move on to the next agenda item. And that will be Fawn Schott from the VOA. She's going to be presenting on their recovery model approach to homelessness. So Fawn, if you, oh, there you are, sorry. And Joanne, do you have her presentation?
Wonderful. Thank you, Kathleen, and thank you everybody for having me here today. I just want to give some context. We started to recognize over the COVID over the last 2 years that the intensity and acuity level of the individuals in our housing had really escalated, and just case management services really wasn't meeting their true needs anymore. So we were really trying to unpack what we might need to do in order to help move people along and ensure that they could re-engage back in the community as fast as possible. So I'd like to share just a quick overview of some demographics of our population that we serve with the next slide. So race ethnicity is pretty similar to, I think, what every organization serves here. 60% of the folks that we serve are actively fleeing domestic violence. They have been chronically homeless for 10 plus years. We have 385 supported apartments across the community for young people 18 all the way to almost end of life, and then 165 shelter beds for youth, teens, women and young adults. What we really recognize about our folks is that they overutilize emergency services just as a standard practice, and also have very limited access to clinical care, mainly because the majority of our individuals we serve are not appointment compliant and not able to receive services really in an easy to access way in the community. So we have started to embed these services and really start to meet people right where they're at so that they can get the services they need and then quickly engage back into the community. So if we could have the next slide, I'd like to share with you our new integrated care model that really brings across a multidisciplinary team approach. Because what we've started to find is we have the housing. That's one of the big things that we're lacking for a lot of our individuals. VOA has the housing. What we really need is this multidisciplinary team. So standardizing our intake, standardizing our assessment, moving people quickly through a care plan, and then engaging a multidisciplinary team that includes not only peer support and case management to help them stay housed in their housing, but then layering on that substance use disorder counseling, mental health therapy, a community nurse that's embedded with from Chaz, and then layering on our MAT treatment, because we know that's critical to the success of the co-occurring substance use and untreated mental health. So we're really embedding this right where folks are at. So transitioning, we are meeting people, we're doing mental health and substance use right in their apartment units. We're embedding it inside of our shelter so that they can prep to be a little bit more housing ready before we transition them from shelter into housing, to reduce that number of individuals that we see failing out of housing because of the untreated mental health and substance use. So within that, if I could have the next slide. Within this, we're really approaching our work with a recovery model. And that recovery model is not only recovery from substance use and mental health, but really from the trauma of experiencing homelessness for 10 plus years and domestic violence and all of the layering factors. So within this recovery model, we're really looking at the way we do our work as stages of change. As people transition through recovery with this multidisciplinary team, when they move into our housing, they're typically in a pre-contemplation stage. So they enter our housing and we really address a harm reduction model where we're doing peer support around use and case management around how we might get connected to mental health services. Maybe chatting about treatment, introducing a nurse to really address those untreated chronic health conditions that they may or may not know they have. As we have folks in our housing and they stabilize a little bit more, we often see active use, and that's happening more and more with COVID. They enter more of this, as they move through the model, contemplation stage, where they transition and get into this preparation and initiating. So what this black line means through here is really that we begin to see people moving forward, and then we also know in a recovery model that people fall back out, and generally not all the way to pre-contemplation, which is the beauty of a recovery model, that we can keep people moving forward in this from preparation to action. Because we really want to focus on outcomes, and outcomes are critically important to VOA, and we want to improve those outcomes. What we want to see is people getting to that action and the maintenance and less relapsing and into the late recovery. And by layering on the mental health, the peer support, the treatment, and the nurse care, all as a multidisciplinary team, those outcomes we can reduce our time into our more restrictive environments, such as permanent supported housing, from more of a 4 or 5 year period down to a 2-year, where we can transition them into the community and really have conversations about employment and engagement back. As we really, we can go ahead and move to the next slide for outcomes. I want to be really respectful of everybody's time and leave questions. So what we really have seen is a decrease since we started COVID and acuity higher and a decrease of outcomes. So we typically pre-COVID, we're housing 30% of our individuals at Hope House Women's Shelter within 90 days. That number has reduced to 21% and it's more in the 180-day mark. And part of that, it's multifaceted. Number one, our co-occurring conditions are higher acuity, as well as a lack of affordable housing or permanent supported housing placements to be able to move them to. Our youth transitional housing, 79% of our young people were able to move to graduate out of our program in that 194-day mark. We're down to 70 and 233 days, taking a lot more time. And our permanent supported housing, 16% used to take us about a little over 1,000 days. And we're literally moving a little bit faster, but only 9%. So we want to get ourselves back up. And we know the determining factor for not being successful in moving is that untreated co-occurring substance use and mental health. So our outcome with this model is to really measure our loss, their reduction in emergency services. We want to really reduce evictions for our individuals because oftentimes the reason we have to evict an individual is because of untreated co-occurring. So by really addressing this right where they're at and meeting them where they're at, we anticipate a reduction in evictions and more positive outcomes. Plus, the obvious is, of course, providing humanity and positive engagement across the community. I think one of the benefits that we have within the structure and leveraging other opportunities that we have within our system is we already have a mechanism that pays for the housing and the leasing dollars and much of the support service dollars that are there. What we know is that fee for service just doesn't cover this model. You can't, like I said, our individuals aren't appointment compliant. They're typically not going to sit for 15-minute increments. So a fee for service model just doesn't adequately meet the needs. What we are really seeking to explore over the next year is the ability to find funds that will be able to fill the gap and from the housing and the support services we received from HUD and Commerce and all of the traditional housing models to wrap services around and have more positive outcomes that are related to long-term housing and graduation out of the higher restrictive environment. I'm going to pause there and just ask if anybody has any questions. I know that was a lot of information in just a couple of minutes. As for implementation, we are implementing this right now within our service delivery model of our units and also our shelters. So we are about 30% implemented now and we'll expand this. It's embedded right now in our permanent supported housing with our adults, our chronically homeless adults, and we're layering it and as well as our foster youth program. And we're by July, we'll have it embedded in all of our shelter programs and as well as our youth transitional housing programs.
So Fawn, thank you. I know, Kathleen, I'm going to step in here just for a sec because I do want to say thank you to Mike and Justin because I'm super excited about the program for our youth as well as Fawn. I want to say thank you for kind of taking this approach to rethink what we're doing within our shelters and moving people out and looking at this model. So I just want to thank you both.
Absolutely. And I anticipate everybody, if you have any questions or you'd like a deeper dive with this and where we anticipate taking this over the next 18 to 24 months, my contact information is on the screen. I would love to reach out and chat with you. And again, I want to thank you for the opportunity to meet today.
Thank you, Fawn. I appreciate your sharing with the group. And I think this is really important because I think we're always looking as the funders, whether it's Healthcare Authority or the MCOs or the ASO, we're looking at, are there gaps? Are there things that we're not there's so much going on. Are there things that we're not paying attention to? And so, Fawn, I appreciate you bringing this forward and sharing this brief update with everyone. And I would challenge the MCOs to reach out to you and you to reach out to them. Look at the funding model and see if there's some creative ways to address some of those needs. Thank you for bringing it to our attention as the ASO. We are looking at that as well too, and are planning to put a concept just for our component of it to the county commissioners for their review. And if they approve that, we will be looking at an RFP for like shelters, transitional shelters in the community with regards to that. So we're trying to think out of the box as well to address this gap. So thank you for bringing it to our attention. And again, I do encourage the MCOs to work with you and communicate with you and see if we can really address this need, because I think so often we do think of it as a traditional behavioral health agency type of setting for serving individuals. And this is, and a different approach. And I think an important approach to take for individuals that are homelessness and are in our shelters with that such a critical need. So thank you, Fawn. Are there any questions for Fawn? All right, with that, I'll think. Oh, did I see anything? Okay, thank you, Fawn. So we'll move on in the agenda to the last item, and that's Allison. If you're there, you can unmute yourself with an update from
I am here. I have not quite managed my post-COVID time management. So like Jason, I am on my way to pick up a kid from track practice. So I'm delighted to be with everyone and see folks' faces. I have a few quick updates that I will share as we near the end of the time here. One is that the Healthcare Authority received budget authority to continue to move forward on a renewal of the Medicaid 1115 waiver. So while we have expected this, it's nice to have the next step in the process complete for us. So they are starting the process of actually developing the application and will be looking for public comment in April and May. We are really excited to see the continuation of the foundational community supports, the long-term care, and then the mental health and substance use initiatives that were part of the original waiver, and some ongoing work around community-based care coordination and accountable communities of health. So lots of details to be figured out in that way, but I think we're eagerly, or we are optimistic about the populations and the structure for the community-based care coordination moving forward. And it tracks nicely for our region with, I think, the ongoing work Better Health Together has done as we think about the evolution of both our accountable community of health work as well as Better Health Together. Along those lines, I'm really pleased that we, since we were last with you, we have up and running a few telehealth, school-based telehealth projects at 6 elementary schools in Spokane Public Schools and up in Newport at both the elementary, middle school, and high school. And seeing some really good progress with, while our volume is pretty low, some kids getting connected to care in that way. So excited about some of the school-based telehealth funding opportunities that have come out of the legislature, as well as some federal funding support for that as well. We are also excited that we were selected by the city of Spokane to act as the Youth Homelessness Demonstration Program Administrator. So we're helping to lead the collective efforts to further establish the youth homelessness project, and that will likely result in an RFP process for some ongoing HUD funds for the next several years. So we're really excited to be working in partnership with the Youth Homelessness Advisory Group, as well as the Continuum of Care Board, to establish a really robust set of programs and supports, which track really nicely with the other presentations that we have heard. And then the final thing I will highlight, and I was hoping by today I would actually have a signed contract with the Department of Commerce, but we are still working through those last little contract details. But we were awarded a little over $600,000 to help support some further navigation services for impacted communities, specifically helping folks sign up for benefits they may be eligible for but haven't been able to access. So that's everything from TANF and WIC to health insurance and basic food stamps as well. So we've got a really robust set of community partners that we will be working with, that will really build on some of our COVID care coordination work, some of our past pathways work, and certainly some of the partners that we have assembled over the last few years. So it feels like things are getting back to the pace that BHT has been accustomed to after a little bit of a lull there as we fought our way through COVID. I think that's what I've got for you today.
Thank you, Allison. Does anybody have any questions for Allison? All right, with that, then we will turn it over if there's any public comments that anyone would like to share. I am not seeing anything. So I think at this point, unless anybody has any comments or questions, I'll turn it back over to Commissioner Cooney to close the meeting.
Thank you, Kathleen. So with that, I think the last thing on the agenda there, one of the things is just a reminder that, you know, for Joanne, that if there's anybody that hasn't signed the agreement, to please contact Joanne so we can get that taken care of. I'm sure she's also going to reach out to you. And then with that, I think item number 10 is just the 2022 meeting schedule. So June 24th, September 16th, and December 9th are the next, make sure everyone just puts those on the calendars for that afternoon. And I think we'll make sure that we do get the handouts and get those out to everybody. So if you, I think Fawn's handouts went out with the agenda. But we'll get Steve Harry's to get out to everyone as well. And I think, Justin, if we can just have a few slides to hand out, just like the one sheet for the teen line, I think that'd be great to have out for everybody. So that way everyone can share that around as well. Anything else from anyone? Not seeing anything. It is 4 o'clock, right on time. So I will adjourn the meeting. Thank you all very much for attending, and we look forward to seeing you in June.
Thank you.